Hello, today I'm going to talk about heart failure. Heart failure is a very common condition in the aging population. It is found in 10% of individuals over 70 years. But what exactly is it? Well, it can be defined as impaired left ventricular contraction or impaired left ventricular relaxation. There are many causes of heart failure. These include hypertension, ischemic heart disease, valvular heart disease such as aortic stenosis, and arrhythmias like AF. In order to fully understand heart failure, we must delve deeper into the pathophysiology of heart failure. When a patient goes into heart failure, their body tries to combat the failing output by certain mechanisms. The first one of interest is the fight or flight mechanism. This is also known as the adrenaline system. This sympathetic system will cause the body to have an increased heart rate or tachycardia. It will also, secondly, cause the body to have sodium and water reabsorption. And thirdly, it will cause peripheral vascular resistance. This peripheral vascular resistance will cause cold peripheries. And if you were to examine someone with heart failure, do a head-to-toe assessment, you would notice from feeling their hands that their hands would be very cold, and this is due to the peripheral vascular resistance. The sodium and water retention caused by the sympathetic or fight or flight system will cause fluid overload, and this can be seen on examining a patient with heart failure as pitting edema in the ankles. The tachycardia caused by the fight or flight or sympathetic system will cause myocardial ischemia, as the heart spends less time in diastole, and diastole is when coronary perfusion occurs. So this system of fight or flight or sympathetic system has backfired. In a normal healthy person with a healthy heart, this system would be useful. But in this particular scenario of heart failure, the fight or flight system is maladaptive. The second system of interest is the renin-angiotensin system. Renin is produced by the juxtaglomerular cells. It converts angiotensinogen to angiotensin 1. ACE converts angiotensin 1 to angiotensin 2. And it is this angiotensin 2 which exerts the effects. Like the fight or flight or sympathetic system, it will cause peripheral vasoconstriction. This will increase the blood pressure and cause cold peripheries, just like the fight or flight system. In addition, the angiotensin 2 will constrict the afferent arteriole more than the afferent arteriole, which increases the EGFR, improving blood flow to the kidneys. And the afferent, E, is the one leaving the kidneys, and the afferent is the one going to. So it constricts the one going out of the kidneys, so more blood flow will go to the kidneys. It also causes release of aldosterone, which causes sodium and water retention. The body uses this RAS system to improve renal function. With a normal healthy heart, this will have no ill effects. However, with impaired cardiac function, this, like the sympathetic system, creates a vicious cycle. So, what we see is that the adrenaline system and the RAS system would be functional if the heart was healthy. However, due to the heart failure, these mechanisms essentially fail. So, what are the symptoms of heart failure? So there's orthopnea and breathlessness, nocturnal cough, and PMD, which is breathlessness at night. And a common question you ask someone in history taking is how many pillows do they lie on? And this is because people with heart failure often wake up breathless at night, and they go and they open a window and they sit up, and that relieves the symptoms. And they will prop themselves up on 1 or 2 pillows. And why is it that when they get up, the symptoms are relieved? Well, you see, fluid transfers across a large surface when they are lying flat, but when they sit up, the fluid will sink to the lung bases and they can breathe more easily. People with heart failure will also be very tired. So the main symptoms are the breathlessness. This is breathlessness on exertion, breathlessness on lying flat, and breathlessness that wakes them up at night. They also have a nocturnal cough, and they have general fatigue and very pronounced pitting edema in the lower limbs. And what would you notice if you examined these patients with heart failure? Well, in the neck, they would have a raised JVP. On palpitation, they would have a displaced apex beat due to cardiomegaly. And they would have pitting edema of the legs. They would also have tachycardia. And on auscultation, they would have a 3rd and 4th heart sound or gallop rhythm. Now, they might not have all of these features, but it's worth being aware of them. And what investigations might you do in someone with heart failure? Well, like any condition that you are suspecting, you should start off with blood tests. These include full blood count, UNEs, TFTs, HbA1c, and lipids. A chest x-ray is also an important investigation, but heart failure cannot be diagnosed on a chest x-ray alone. An ECG is rarely normal in heart failure, as many people with heart failure have AF, and this will be visible on the ECG, or they might have had a previous heart attack, myocardial infarction, and they may have Q waves present, or they might have a left bundle branch block. A common blood test used in diagnosing heart failure is BNP. This was first noted in the pigs of Brain, and it was later found to be of use in detecting heart failure. It's very non-specific and is raised in a lot of different conditions other than heart failure, but it is considered a good tool to exclude heart failure. For example, if the BNP comes back less than 100 pg per milliliters, you could consider that heart failure was not a diagnosis. Another test of use is echo. This will tell us the ejection fraction. Many patients with heart failure have an impaired ejection fraction, but some have preserved ejection fraction. Ejection fraction does not always correlate with severity of the condition. A common exam question is what changes can be seen in patients with heart failure on a chest x-ray. and this can be remembered by A, B, C, D, E. The A is for alveolar edema, the B is for curly B lines, the C is for cardiomegaly, which caused the displaced apex beat we discussed earlier, the D is for diversion to the upper lobes, and the E is for pleural effusion. Now, finally, we will talk about the management of heart failure. You should first talk to the patient about stopping smoking and restricting their alcohol consumption. Patients with heart failure should also be advised to reduce salt and fluid. They are advised to have a pneumococcal vaccination and annual flu vaccinations. In terms of pharmacological interventions, there are two key drugs: ACE inhibitors, which work on the RAS system that we discussed in detail earlier, and beta blockers, which work on the sympathetic or fight or flight system. These drugs are first line and reduce the morbidity and mortality associated with heart failure. Loop diuretics are also used, but these do not reduce the mortality associated with heart failure. They are used to provide symptomatic relief for the pitting edema. In heart failure, there are 4 drugs which can reduce mortality. These are ACE inhibitors, beta blockers, ivabradine, and aldosterone antagonists. ACE inhibitors and beta blockers are first line, and they are started slow at a low dose and titrated up. So that concludes our session on heart failure. In brief, heart failure is a failure of the pump action of the heart. While previously heart failure was thought of as left and right failure, it is best to realize that left heart failure ultimately causes right heart failure. The symptoms of heart failure include fatigue, cough, breathlessness, and PND. Tests include chest X-ray, blood tests, ECG, and echo, and the first line drugs are ACE inhibitors and beta blockers, but ultimately 4 drugs can reduce mortality. Thank you for listening to this presentation. If you enjoyed this video, don't forget to give it a like and subscribe to this channel to see more medicine videos.